Hello everyone, welcome to the next module. In this one, we'll be talking in detail about the chief complaints as well as the HOPI, that is the history of presenting illness, HOPI. The way you present these two things is going to differentiate you from an average student, from a top ranker, from a gold medalist. So this is very, very essential that you almost always pay a very close attention to whenever you are writing the HOPI and when you are presenting the HOPI. The HOPI and chief complaints should sound like a story to you. It should be always in the patient's word. It should never involve any scientific terms whatsoever. And most importantly, at the end, by the story, you should be able to get to what system you're pointing towards, and specifically you should have a few provisional diagnoses in mind plus 2 to 3 differential diagnoses in mind. So always remember HOPI is super duper useful. Now let's see what is the chief complaint in the first case. So chief complaints is the reason why the patient is coming to your OPD. The patient might have so many complaints. The patient might have yellowish discoloration from 3 weeks, he might have fever 4 weeks ago, but now he's getting abdominal distension or abdominal pain, and that is the reason why the patient has come to you in your OPD, and that is your main chief complaint. Now let me tell you exactly how do you elicit the chief complaints from the patient. When you are approaching the patient, you ask them, "Kya hua? Why have you come to the hospital? What is the reason for you to come to the hospital?" And ask them that when was the last time when you were perfectly fine? When was the last time you were in perfect good condition of your health? And that is from where the entire story will start. I was apparently all right. That's how you start presenting your case in your chief complaints. The patient came to the OPD with chief complaints of maybe fever for the 4 weeks, then yellowish discoloration of the eye for the 3 weeks, and then swelling of the abdomen since 1 week. So this is exactly how you approach the chief complaints. And always remember, friends, there should be not more than 3 chief complaints in your entire history. 3 chief complaints is still quite a lot. If you can just narrow it down to 1 or 2 chief complaints, and that is it. If you go more than 3, then it becomes a bit vague, it becomes a bit irrelevant. So no matter if patient even tells you 10 chief complaints, you will narrow it down to the 3 most important, 3 most relevant things that fit into your story. Now this is just a tip from my side to you guys. This should not be applied during your vivas, but whenever you are approaching a patient, you already have a bit of an idea about what the diagnosis of the patient is. You might know that this is a GIT case by seeing the swelling of their abdomen, that is the ascites. You might already see like it's an RS case by seeing the patient is coughing. You might already know that it is a CNS case by seeing the gait of the patient. So you have already localized what kind of system you're going towards. So always remember, always write the chief complaints in the system that you want your case to go towards. If you're writing the patient maybe has some GIT issues, the patient also has CNS issues, he also has CVS issues, that's when your case becomes a bit diluted. Now, in most of the cases, just limit your chief complaints to 1 system, max to max 2. A lot of the times, our diseases involve more than 1 system. For example, a patient of a cerebral palsy or patient of stroke might develop aspiration pneumonia. So your case will be predominantly of RS, which is aspiration pneumonia, but the CNS examination will have to be included so that our case of aspiration is actually supported. Whenever you're writing the chief complaints, always make sure that you have the chronology in order. That means whatever happened first to the patient should be written down the first. For example, fever 4 weeks ago, that is the first thing. Next, yellowish discoloration 3 weeks ago, and lastly, abdominal distension 1 week ago. This is how you have to write. You have to include what is happening and since when was the last time that has actually happened. This is how you make sure your chief complaints are in order, and that is how you actually form a story. Without even going into the HOPI, you can think that I'm talking about some sort of viral hepatitis that is going on in the patient, or at least some sort maybe of an obstructive jaundice kind of situation. Because we have fever, then we have jaundice, as well as we have got abdominal distension, that is ascites. So it might be anything, but you have at least localized that this is a GIT issue, and we can take it from there. So that's all that I've really wanted to know you with chief complaints. Again, just telling you, chronology is most important. Keep it relevant and keep it to the system that you're going toward and where you want to take your diagnosis. If you want your diagnosis to go to aspiration pneumonia, your chief complaint should consist of RS, and then if you want to take it to maybe stroke, it should complain of CNS. So, and if you want to take it towards the CVS side, it should obviously have the CNS issues like chest pain, like palpitation, like breathlessness. Now that's done, let me talk to you a bit more about HOPI. HOPI, or history of presenting illness, is very, very essential. This is a story in the patient's own words, and you have to not alter these words at all. And very, very essential is that whatever chief complaints that you have written, all of these chief complaints should be told in detail in the HOPI. If you have written down 3 chief complaints, that is fever, next you have written down yellowish discoloration of the eyes, and thirdly, a distension of the abdomen. These are the 3 chief complaints. In our HOPI, we'll be taking all of these 3 chief complaints and examining them in detail. So let us start. In HOPI of any particular symptom that you've got, 5 things you have to do without fail, that I like to call as OPD AR. So you're going to then OPD, and it's got augmented reality in it. So OPD AR, you have to remember, O is for onset, P is for progression, D is for duration, A is for things which are augmenting it, and R is for relieving factors. So these are the things of anything. Let me talk to you with respect to, let's say, fever. So in fever, onset, progression, and duration, this is very important, and aggravating factor, relieving factor. Aggravating factor might be night, the fever is more, that what we typically call as evening rise of fever seen with tuberculosis tuberculosis. And next, relieving factor might be a paracetamol that the patient is having, so relieved on medication. Onset could be it was insidious in onset or it was sudden in onset, like the patient was apparently all right and suddenly developed a fever of maybe 101 degree Fahrenheit, and it was continuous in nature. Its progression that is continuous, and duration, the fever lasted for 2 days. It was relieved by medication. It had no specific aggravating factors. So these are the OPD AR features of fever. Always remember, this is of fever, then you will do the same thing OPD AR for your particular yellowish discoloration, then OPD AR for your particular abdominal distension. There are a few important things that you have to keep in mind. Not all symptoms you have to do all of this. In some symptoms, you have to add some additional features to it. For example, pain. When we talk about pain, OPD-AR obviously is there, but there is a better mnemonic to remember everything related to pain, that is Socrates. So site, onset, character, radiation, associated factors, time, and then relieving factors. So this is a Socrates principle for pain that you will be using. So whenever you're describing a pain, you will describe it using these few things. So what is the site of the pain? The site of the pain is the chest. So chest is the site. Onset, it started yesterday. It was insidious in onset. The progression of the pain, there is no progression of the pain. It is static. It is retrosternal in origin. Then it is radiating towards various places. That is radiating towards the jaw, radiating towards the left hand, radiating towards the epigastrium. These are the radiating features. Associated features that if the patient has nausea and vomiting during the pain, if the patient is having some convulsions with the pain, if the patient is having some sort of loss of consciousness with the pain, all of these are associated features. Apart from that, the relieving factor of pain, the patient's pain was relieved by medications. So this is just an example of how you will write the HOPI of pain. Now that I've told you about pain, let me see how are we going to approach this particular finding that I discussed with you. So 4 weeks ago, the patient had fever. We will write about the OPD-AR, like I told you. Then the patient had abdominal distension. So whenever you're talking about the swelling, there are a few things you have to remember. There is the site, there is the size, there is the surface of the swelling, and there is the skin overlying the swelling. These are very important things when you're talking with respect to the swelling. I'll be discussing more about this when we go to the surgical aspect and the case presentation. So when you're forming an HOPI, this is exactly how it should look like. As you can see on screen, this is a very beautifully written HOPI for a case of jaundice, that is a case of viral hepatitis leading to jaundice. So you can copy this HOPI if you want, and this is how you present it. Since we have already talked about fever, let me tell you a bit more about what are the questions they can ask you from fever. So fever is rise in body temperature. Classically, it is more than 98.6 degree Fahrenheit or 37.1 degrees Celsius. And this rise in body temperature has 3 basic patterns that we have recognized so far. One is the continuous fever. That means it is not going down no matter what. And the fluctuations are less than 1 degree Celsius. That is the continuous fever. Most commonly associated with viral illnesses and bacterial sepsis, continuous fever is there. Secondly, you have got the intermittent fever. So intermittent fever basically goes away, comes back, goes away, comes back. So the patient is having fever for 2 to 3 hours, then it's going away. So a dengue fever is classic, a malarian fever is classic. And lastly, we've got the remittent fever. In remittent fever, the fever is continuous. That means it is not going to come down, but the fluctuations are more than 2 degrees. So that is few questions they can ask you about fever. Now this HOPI module is completed. One thing which I really want you to focus on over here is that not to mention the past history over here. If a patient is diabetic, if a patient is hypertensive, you don't mention it over here. We have got a separate column of past history over there. So this was all I needed you to know with respect to this module on HOPI and chief complaints, my friends.